السلام عليكم ورحمة الله وبركاته. Our lecture today is actually not a single lecture. I can see it as three different lectures combined together. So the first part or the first lecture is about metabolic liver diseases. Okay. So metabolic liver diseases, there are so many diseases, but the three most common of them are the hereditary hemochromatosis and Alpha-1 antitrypsin deficiency and Wilson's disease. Of course, we know hereditary hemochromatosis is the one concerned with iron. Alpha-1 antitrypsin deficiency is concerned about the protein Alpha-1 antitrypsin, and Wilson's disease is the one concerned with copper. Okay. Let us see what happens in those three common metabolic liver diseases. The first one is the hereditary hemochromatosis. It is an inherited disease, autosomal recessive, characterized by iron deposition in various organs, leading to eventual fibrosis and functional organ failure. Whatever the organ that the iron is getting deposited in, it will be damaged in the brain, in the heart, in the liver, in the pancreas, in the gonads, in the skin, everywhere where the iron is deposited, it will cause, and of course, the joints and the muscles as well. We don't forget that. It's very common, musculoskeletal disease. Also, okay. So this autosomal recessive disease is due to a mutation of something called the HFE gene, which is in the short arm of chromosome number 6. So this mutation in the HFE gene, which is autosomal recessive in inheritance, will cause our problem. What is our problem? Our problem that normally we absorb the iron from the gastrointestinal tract, from the small bowel, duodenum, and so. There is a limitation for this absorption. We do not absorb except the amount of iron that our body needs. That's why it's not about increasing the iron intake markedly. That is going to correct the problem of needing iron. So the mutation of this HFE gene will interact with the intestinal transferring receptor, leading to the normal loss of intestinal control on the iron absorption. So the iron will be absorbed in mega amount, inappropriately, in amounts exceeding the capacity of serum transferrin. So if the serum transferrin will be unable to take all the excessive iron that is absorbed from the gastrointestinal tract, this means that the excess iron will be deposited in the tissues like the liver and other tissues on the long run and causing its damage. The clinical presentation, of course, depends on where the iron is deposited. The overt clinical manifestation usually occurs in males more than females. And this may be explained that the females, they have continuous mode of losing their iron through the menstruation. Affective individuals usually in their 50s, but of course, hemochromatosis can present itself a little bit earlier than that in the 30s or in the 40s. Of course, there is a classic triad of bronze pigmentation of the skin due to the melanin deposition, hepatomegaly, and diabetes mellitus secondary to iron deposition in the pancreas. And this is the explanation why hemochromatosis was first known as bronze diabetes, because patients, they have diabetes and they have, of course, bronze coloration of their skin. Here we can see the bronze coloration of the skin. We can see also that the patient is having jaundice. And this is the way the liver looks when there is excess iron deposition in it, and hemochromatosis will appear in the pathology. The clinical presentation, of course, according to the organ where it is deposited. When they are deposited in the gonads, it will, and in the pituitary, in the pituitary, it will cause hypogonadism secondary to the affection of the hormones, sex hormones, and the gonadotropins. When it is deposited in the heart, it will cause, of course, heart failure and arrhythmia. In the skeletal tissue, as I said, it will cause osteoporosis, arthritis, and myalgias, and destruction of the joints. And of course, in the liver, on the long run, they are also oncogenic, and they can cause hepatocellular carcinoma. It's one of the commonest it's one of the diseases with the highest rate of transformation to hepatocellular carcinoma on top of cirrhosis. 30% of cases with with hemochromatosis will eventually develop hepatocellular carcinoma. It is a very, very large number. Investigations, it will be elevation in the serum iron and ferritin. Of course, with the reduction of total iron binding capacity, the liver enzymes are usually elevated, and liver biopsy with iron content estimation will will show us the extent and the confirm the diagnosis. Of course, liver biopsy may be replaced sometimes by MRI, where it can detect the iron deposition in the pancreas. Differentiate this condition from the usual cases of iron overload, where it is called hemosiderosis, not hemochromatosis, in which the hemosiderosis, the liver only is going to be affected by the overload of iron deposition, but not in the diabetes. What are the treatment options? Of course, venesections to decrease iron load. It is similar to menstruation in females. Chelation of iron by despiroxamine, and liver transplantation in decompensated cirrhosis. But let us all remember that this liver transplantation, it will not reverse the disease process, because the disease process is genetic in nature. I mean, you did not treat the genetic abnormality. It will only improve the quality of life and decrease morbidity, or maybe when hepatocellular carcinoma develops or something like that. So it is just, we said in the lecture of liver cirrhosis that liver transplantation is a definitive treatment. Here, it is not the definitive treatment. It is a temporary treatment for the condition. So the best, of course, is gene therapy in early intrafetal and in early life, or the chelation of second disease is alpha-1-antitrypsin deficiency. It is due to deficiency of alpha-1-antitrypsin. And we know that this causes disease not only in the liver, but also in the lungs, particularly in smokers. And we know that alpha-1-antitrypsin deficiency is one of the causes of pulmonary emphysema and the chronic obstructive pulmonary disease. Deficiency of alpha-1 antitrypsin is also autosomal recessive in the inheritance, similarly to hemochromatosis or hereditary hemochromatosis. The main role is alpha-1 antitrypsin is to inhibit the proteolytic enzyme neutrophil elastase. So when this does not get inhibited, it will lead to accumulation of proteins, and this will lead to protein-protein interaction occurring between the reactive central lobe of one molecule and the beta plated sheet of the second lobe sheet, which lead to loop sheet polymerization. This exactly how can this cause liver damage is not very certain, and there is a postulation that for a liver damage to happen, it needs a second hit, like alcoholism, like hepatitis, like alcoholic liver disease, non-alcoholic liver disease, other liver disease. It needs a second hit to reach its final destination of liver cirrhosis and compensation, and also the development of hepatocellular carcinoma. The clinical presentation may vary between presentation in a childhood and may require transplantation, or 10 to 15% in adult population developing cirrhosis over the age of 50. But the majority of patients, they will have respiratory problems because of the pulmonary emphysema that they have. Approximately 5% of patients die of the liver disease. Investigations will show low alpha-1 antitrypsin in serum. Histologically, it will show the periodic acid shift positive diastase-resistant globules that contains the alpha-1 antitrypsin in the peripheral hepatocytes, as we can see in the picture. Fibrosis and cirrhosis, of course, will develop and can be present in the liver biopsy. What are the treatment options? Unfortunately, there is no definite treatment. The treatment is only symptomatic to liver cirrhosis manifestations and complications. Liver transplantation, again, it will correct the decompensation of cirrhosis, but will not affect the basic disease process, which is genetic in nature. So it will only improve the quality of life and decrease morbidity, but it will not revert the disease that needs genetic gene therapy in fetal life. Wilson disease is also an autosomal recessive, so all of them are autosomal recessive. Disorder in copper metabolism leading to deposition of copper in various organs like liver, basal ganglia, and the cornea. And history of family consanguinity is common to be successful to cause an autosomal recessive. Pathophysiology is dietary copper, of course, is usually absorbed from the stomach and upper small intestine, like the duodenum. It is transported to the liver loosely bound to albumin. In the liver, it is incorporated with ceruloplasmin. This is a glycoprotein formed in the liver and secreted in the blood. Problem is that later on, copper is normally secreted in the bile. In those patients with Wilson's disease, they have a defect in hepatic synthesis of such ceruloplasmin. This means that the copper will not be conjugated to ceruloplasmin. It will not be carried by ceruloplasmin, leading to failure of hepatic metabolism and excretion of copper. So what's going to do? The liver will be unable to excrete this copper, and the copper will deposit inside the liver, unable to be excreted into the bile. So it's going to be deposited in the liver, leading to progressive damage as well as in the brain, in the basal ganglia especially, and in the cornea, causing what is commonly known as Kaiser-Fleischer rings. So clinical presentation may vary from fulminant liver cell failure, common in children, to minor lab abnormalities in liver function tests in adulthood. And finally, liver cirrhosis and chronic liver cell failure will take place. The following is the classic triad we said about the clinical findings. The liver, that is hepatomegaly and cirrhosis, central nervous system in the form of tremors, dysarthria, involuntary movement, and eventually dementia. Something that is similar to Parkinson's disease. And of course, in the eye, the deposition of the copper in the descent membrane causing the Kaiser-Fleischer ring we can see in the picture. And of course, in the blood, they can cause also hemolytic anemia. Investigations, serum copper and ceruloplasmin are going to be reduced and increased 24-hour urinary copper excretion. Liver biopsy will show acute or chronic inflammation and cirrhosis. Measurement of liver copper content is not usually done. The main test is going to be done is the increased 24-hour urinary copper excretion. Of course, the slit lamp will show the Kaiser-Fleischer ring in the cornea, and the screening of other family members and hemolytic anemia may be present. The treatment, chelation of copper with dipenicillamine. Dipenicillamine is the copper chelator. liver transplantation and fulminant failure and decompensated cirrhosis. But again, remember that transplantation will not affect the basic disease as it is genetic in nature, but will improve only the quality of life and decrease morbidity. Okay, so this is our first lecture. Our second lecture is the non-alcoholic fatty liver disease or NAFLD. And now the nomenclature is getting changed recently into metabolic associated steatotic liver disease. Okay, so this is by far the commonest hepatic disease in the whole world. There are some definitions. Non-alcoholic fatty liver disease, it means excessive hepatic fat accumulation that is usually associated with insulin resistance, and steatosis in liver biopsy is exceeding 5% of hepatocytes, and we should exclude secondary causes like hepatitis and so, and alcoholic fatty liver disease. Maybe this is the way why the new nomenclature is adopted, and now little amounts of alcohol consumption and the presence of other liver diseases are accepted under the umbrella of metabolic associated steatotic liver disease. That is furtherly subdivided into a spectrum of fatty liver only which is only steatosis without inflammation or with mild inflammation, and there are non-alcoholic steatohepatitis, and from the word hepatitis, it means that there is inflammation, and the inflammation, similarly to any hepatitis, it will go through the stages of fibrosis from early fibrosis, which is F0 to F1, to fibrotic stage, which is F2 or F3, to the complete cirrhotic form, which is F4, and they can even turn into hepatocellular carcinoma at any stage. I mean, it does not need to develop complete cirrhosis to turn into hepatocellular carcinoma. The definitive diagnosis of NASH, of course, will require a liver biopsy. But there are some other ways to assess the hepatic fat, like the MR spectroscopy, and of course now there is an addition to the FibroScan, something called the CAP score, which is controlled attenuation parameter, which can measure the fat content in the hepatocytes and then numerically decided for follow-up later. Okay, what is the spectrum, as we said, to cirrhosis and hepatic carcinoma? The histological features, they can be vary from normal to steatotic liver disease only, to steatohepatitis, then to cirrhosis and development, of course, of hepatocellular carcinoma. Global prevalence is very, very high. Almost 25% of the general population. It means that 1/4 of the Earth population, they have a form of non-alcoholic fatty liver disease, and it's even higher in the Middle East area reaching up to 32%. And among those with hepatitis, they are almost 20%, which means that they are about 6.5 of general population. It's a very, very large number. And of course, advanced cirrhosis and fibrosis, they can also affect 15% of patients with NASH. So there is going to be like 1 or 2% from the whole population that is having already cirrhosis without any kind of symptom. Again, this is the spectrum and the estimate of number that the majority of patients, they are in the area where there is starting fibrosis and development of fibrosis until the hepatic. What about the prevalence among the high-risk groups? And we have two high-risk groups, which are the obese and diabetics. In obese, up to 95%, they are having non-alcoholic fatty liver disease. Among them, almost 1/2 they are going to have NASH. What about type 2 diabetes? For type 2 diabetes, up to 80% of patients are going to have NAFL, and up to 80% are going to have NASH. It's very, of course, very, very large numbers. What are the major causes for non-alcoholic fatty liver disease? Of course, insulin resistance, type 2 diabetes, obesity, hypertriglyceridemia. Of course, we can see that they are all metabolic disorders and they are part of metabolic syndrome. That's why it is now called the metabolic associated. And risk factors including nutritional abnormalities such as prolonged parenteral nutrition, rapid weight loss, and kwashiorkors in pediatric population. Of course, surgical alterations of the GI anatomy like gastric and jejunal bypass. Patients who perform bariatric surgery, they are very prone to develop non-alcoholic fatty liver disease. So it is ironic. They make this because they are obese and they want to fight the non-alcoholic fatty liver disease, but in fact, the rapid accumulation of fatty acids into the liver after the rapid weight loss following such operations may also help to increase the non-alcoholic fatty liver disease, not treat. Also, there are some drugs which are implicated in such condition, like steroids, estrogens, chloroquine, tamoxifen, and amiodarone. Pathophysiology of non-alcoholic fatty liver disease is the progression is called multiple hit theory or multiple parallel hit theory. It means that there are many factors, numerously, genetic, environmental, and individual. They work all separately and in conjunction in different pathogenetic combinations and different parallel and inter crossing pathways to cause the disease. The disease causes expansion of the adipose tissue in obese will diminish the ability to store the excess energy. Adipocyte dysfunction will develop, and insulin resistance will be increased, and this will lead to lipolysis. This circulating free fatty acids and leptin increase and adiponectin decrease, resulting in intrahepatic fat accumulation, something called simple steatosis. This is furtherly amplified by the high dietary fat and carbohydrates, of course, commonly observed in obese, and the latter will increase the de novo synthesis of lipid in the form of de novo lipogenesis. So more and more, the condition will increase and then will start to stimulate the immune cells. And we know from before that stimulation of immune cells does not always carry a good news because it will produce cytokines and interleukins, which can cause inflammation. So there would be a chronic intrahepatic inflammatory process. This intrahepatic inflammatory process, along with the lipotoxicity and the glucotoxicity, will develop will play a role in the transformation of the simple steatosis into steatohepatitis and the progression to non-alcoholic steatohepatitis. This will furtherly cause mitochondrial defect, endoplasmic reticulum stress, oxidative stress, or they are hepatotoxic and hepatoinjurious, along with the NASH that is coming out from simple steatosis by the process that is still ongoing. So that when inflammation prolongs, of course, we know that hepatic stellate will come to seize this inflammatory process, and hepatic stellate cells, they seize the process by fibrogenesis, which will start to form liver fibrosis and then aggravation to develop cirrhosis, unfortunately. So it all starts with adipocyte dysfunction and increased insulin resistance and decreased lipolysis, and this will increase the accumulation of intrahepatic fat and start of inflammation and fibrosis, and literally, of course, will cause cell death and which is going to be cirrhosis. And here we can see the dysfunction of adipose tissues and the increasing flux of fatty acids and the fats into the liver, along with the hyperinsulinemia and insulin resistance. This, of course, under the influence of genetic and environmental and other factors we mentioned. Of course, those patients with such dysfunction, they are more prone to cardiovascular risks, because we can see now that they have metabolic syndrome, they have insulin resistance, they have a problem with dyslipidemia, and so on. And of course, the prolonged inflammatory and the procoagulant status of the chronic subtle inflammatory process in the liver will increase the cardiovascular risk, increase the risk of ischemic heart disease. That's why it's called the liver heart connection. And when they did the research and they made something called meta-analysis, where they analyzed all the researches, they found that all the parameters that are going to be measured for cardiovascular risks are all increased in patients with non-alcoholic fatty liver. What are the investigations? Investigations, of course, going to be aminotransferases, but with special concern about glutamyl transpeptidase, gamma GT, which is going to be elevated, especially in patients with NASH. Serum albumin and bilirubin may be normal, and later, of course, serum albumin will be decreased and bilirubin will increase when cirrhosis develops. Of course, there would be dyslipidemia with serum hypertriglyceridemia, hypercholesterolemia may be present. Ultrasound will show, of course, enlarged right liver, fibroscan elastography, and the controlled attenuation parameter, the CABT scoring, will be used. MRI spectroscopy and MRI measurement of fat content in the liver can be used. Of course, liver biopsy can detect the presence of inflammation, necrosis, fibrosis, and steatosis. How we can treat NASH currently? Mainly lifestyle modification, the weight loss of 5 to 10% of body weight, along with exercise of about 150 minutes per week. Some anti-diabetics can be used, like pioglitazone, vitamin E, but not in diabetics, obsalic acid, but there are so many concerns about it because it increases the cardiovascular rate, so it is cardiovascular risk, so it is now omitted and banned and not recommended to be used. And there would still be so many medications still in the pipeline that are going to be used in the market soon, inshallah. Okay, so this is the end of our second part or the second lecture, and we go to the last lecture or last part, which is drug and liver or drug-induced liver injury, which is also, as well as the NASH or the non-alcoholic fatty liver disease. It is very, 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 very important because of the abuse and maluse of medications and the drugs all over the world, and over-the-counter drugs and harmful drugs and the drug-drug interactions and so many sophisticated things that is responsible for liver damage and liver injury in majority of patients we see every day. Liver, of course, we know is a major site of drug metabolism. Drugs and are converted from fat-soluble to water-soluble substance that can be excreted in the urine or bile. Drug-induced liver injury is the most common cause of abnormal liver function. So if we take like 100 person with abnormal liver functions, we will find that the majority of them, they are going to be due to drug-induced liver injury. And high index of suspicion should be thought, especially after exclusion of other causes. So in every case and in every patient with the derangement of liver functions, you must think that there is drug injury underlying. Drug hepatotoxicity, damage of the liver by drugs, or what's called DILI, or drug-induced liver injury, is usually classified as being either predictable, which is dose-related. I know that this drug is harmful to the liver, so when I keep on using it, it will harm the liver, or non-predictable, which is not dose-related. You can take this drug once, and a hepatotoxicity might develop. And I think this was in the pathology, in the physiology, was called in the pharmacology, I mean, it was called idiosyncrasy. So mechanism of DILI, they can be one of 6 mechanisms. The first mechanism is disruption of intracellular calcium homeostasis, or Disruption of bile canalicular transport mechanisms, something similar to what happened in metabolic liver disorder. Formation of non-functioning adducts like enzyme drug, which may then lead to presentation on the surface of the hepatocyte as new immunogen. Immunogen? Oh, immunogen, this means that it's going to be attacked by T lymphocyte cells. And then induction of apoptosis, which is programmed cell death, or inhibition of mitochondrial function, which prevents fatty acid metabolism and accumulation of both lactate and reactive oxygen species, or ROS. Here is a diagram that shows different ways or different pathophysiologic postulations about how the drugs cause liver damage. What are the patterns of DILI or drug-induced liver injury? They are very, very versatile and very, very different. The predominant mechanism or combination of mechanisms determines the type of liver injury, that is hepatic, cholestatic, or immunological. Immunological means that includes skin rash, fever, and arthralgia, like serum sickness syndrome, eosinophilia, and circulating immune complexes, and antibodies are usually also detected. So it can be either hepatic, it can present itself in the form of hepatitis, elevated liver enzyme, and elevated bilirubin, fatigue, and so on and so on. Cholestatic, bilirubin is markedly elevated with mild or minimal elevation of liver enzymes, or immunological, that either or, including skin manifestation, fever, arthralgia, and so on, and eosinophilia, and so on. So, when a small amount of a hepatotoxic drug whose effect is dose dependent, for example, like paracetamol, we know that maximum dose is 4 grams. Any patient who is going to use more than 4 grams of paracetamol per day is going to develop liver toxicity. So, large proportion of it will undergo conjugation and glucuronide and sulfate, with glucuronide and sulfate. The remainder is metabolized by microsomal enzymes to produce toxic derivatives that are immediately detoxified by conjugation with glutathione. So remember, when I ingest something that is known to be hepatotoxic in certain dose, but I take it in small amounts, okay? The large proportion will be conjugated to glucuronide and sulfate. The remainder is going to be metabolized by microsomal enzymes to produce toxic derivatives that is going to be detoxified by glutathione. Okay? If larger doses are ingested, the former pathway becomes saturated, and the toxic derivative that is produced is going to be in amounts that is unable by the liver to be detoxified and conjugated with glutathione. And the drug will accumulate and cause the liver injury. Once the hepatic glutathione is depleted, large amount of toxic metabolites will accumulate and produce the damage. Okay, so it happens on 2 steps. First step, that the large proportion will be conjugated to glucuronide and sulfate, and the remaining part will be metabolized to form the toxic product that is conjugated by glutathione. After a while, the glutathione will be depleted, and we will end up with only the toxic product that is going to cause the liver injury. Can you see? Can you see this table? These are types of liver damages and the correlated drugs. Like, for example, zone 3 necrosis with paracetamol, cocaine, piroxicam, and so on. Zone 1 necrosis, ferrous sulfate. Microvesicular fat, sodium valproate, antiepileptic. Tetracycline, antibiotic. Steatohepatitis, amiodarone, antiarrhythmic. Nifedipine, antihypertensive. Synthetic estrogen. Fibrosis, like methotrexate. Chemotherapy and and DMARD, disease modifying anti-rheumatic drug. Vitamin A, retinoids, the one used in for treat acne. Arsenic, sinusoidal dilatation, contraceptive pills, and anabolic steroid. Uses hepatis, azathioprine, immunosuppressant. Veno-occlusive, like cyclophosphamide. Acute hepatitis, isoniazid, rifampicin, methyl dopa, atenolol, enalapril, verapamil, ketoconazole, antifungal, cytotoxic drug, clonazepam. blah, 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 chronic hepatitis, methyl dopa, and fenofibrate, and so and so and so and so on. It is endless, and almost any drug in the world can be harmful to the liver, and any drug can cause liver damage and can increase the liver enzymes. Clinical presentations, they may vary from fulminant liver cell failure, especially in children, and up to minor lab abnormalities, just elevation of liver enzymes, like patients who are taking statin, for example, for dyslipidemia, they, after a while, they can find that the liver enzymes a little bit elevated because of that. Diagnosis, of course, by suspicion and the exclusion of other causes, and of course, history of ingestion of the drug. Of course, the pathology is not going to help a lot because the pathology will vary according to the kind of liver damage, but it will not say that I am the drug-induced liver damage. Toxicology screen sometimes, and liver biopsy is not there. Therapeutic options, of course, stop the drug. Specific antidote, like cases of acetaminophen, paracetamol, is the N-acetylcysteine. Conservative and symptomatic treatment, plasmapheresis sometimes in severe forms in like patients with fulminant hepatic failure. Liver transplantation sometimes will be needed in cases of fulminant liver cell. What about drug prescription in patients with liver disease? Metabolism of drugs are impaired in severe liver disease, those with jaundice and ascites and hypoalbuminemia. As the removal of many drugs depend on the liver and the liver blood flow and the integrity of the hepatocytes, so in general, therefore, the effect of drug is prolonged by liver disease and also by presence of cholestasis. So beware that or watch it that when you prescribe a drug in a patient with chronic liver disease, that this drug is not going to be destroyed and detoxified and action will be prolonged. This is further accentuated by orthosystemic shunting, so that the drug will even bypass the first pass extraction by the liver. With hypoproteinemia, there is decreased protein binding of some drugs, so the availability will be increased. Bilirubin compete with many drugs for the binding site of serum albumin, so the free part will be increased. Encephalopathy, care must be taken in prescription of drugs that's having central depressant action, such as codeine, anxiolytics, narcotics. Other common drugs to be avoided in cirrhosis, like angiotensin converting enzyme inhibitors, because they can increase the chance of developing hepatorenal syndrome or hepatorenal failure, of course, as well as the use of non-steroidal anti-inflammatory, which increase the incidence of bleeding. And thank you very